Good evening, colleagues, and welcome to today's webinar. We're going to discuss the optimizing surgical outcomes through the evidence-based acute pain management protocols and emerging technologies. We will explore intraoperative, preoperative, postoperative guidelines, and followed by the new innovations in transforming acute pain management. Our first speaker today is going to talk about the preoperative guidelines, which is Dr. Carina Lee. Dr. Lee is based in Hong Kong. She's an anesthesiologist. She has a diploma in pain management, a fellowship in regional anesthesia. She's a board member from the Pain and Medicine in Hong Kong College of Anaesthesiology. She is a past president from the Hong Kong Pain Society, and she was elected president and founder of the Multidisciplinary Musculoskeletal Ultrasound and Pain Management. Dr. Lee is has a lot of research interest in regional anesthesia, acute pain, and ultrasound applications. So we will welcome her and have a nice talk about preoperative guidelines in pain management. Hi, Dr. Lee. We're expecting a great talk.
Thank you. So can you see the screen?
Yes.
Okay, so today my talk is about the perioperative acute pain preoperative assessment. And I have no conflict of interest. So the preoperative acute pain management guidelines, actually different societies and different countries, they all have different guidelines. So in today's talk, I'm going to introduce you the general concepts because actually because of different countries, they have different psychosocial economic status. And so some countries' guidelines may not be applicable in some other countries. So actually it's getting more popular with the terms of transitional pain management. So that means actually is including the preoperative assessment and also the early pain interventions and as a kind of preoperative anesthetic clinic assessment. And then we have some collaborative care in the multidisciplinary approach. So the whole idea is to have a thorough assessment of the patient history, apart from the anesthetic history and other medical risk factor. We also identify the opioids and other pain history risk factor for better transitional pain management in order to improve the outcome to avoid chronic pain status. And especially for those chronic pain opioids user, which is more a problem in America these days. So I will briefly introduce the guidelines as well. So early pain interventions, not only including our doctors, anesthetists planning, it's very important that we have a proper communications with our patients and their family. So we can educate the patients before the surgeries in the anesthetic clinic and the plan for multimodal analgesia. We may possibly also prescribe the patients in the clinic with the preemptive analgesia, either orally or transdermally with the buprenorphine patch, in order to help minimize postoperative pain and enhance recovery. And some specialty is also very important that we collaborative care with surgical colleagues in a kind of multidisciplinary team meeting, such that we can decide on individual cases, especially true for bariatric surgeries, some particular surgeries that may cause more pain status. So according to the British Pain Society guidelines and most of the American guidelines, the most important is that we have to have the patients have pre-admissions clinic, and then we have the pain assessment to guide the preemptive analgesic regimes. And then we have to plan before the date of admissions of the patients. We also have to encourage the use of multimodal analgesias, and also we encourage the patients, if they are chronic pain patients, to continue their own analgesics. In some difficult patients, we will consult pain clinic and chronic pain physicians, and also maybe put it up as multidisciplinary pain case discussions, such that we can plan ahead for prepare the patients, optimize the patients, and non-pharmacological strategies for the postoperative pain is always encouraged. If the patients is allowed and have low contraindications with regional anesthesia, either with neuroaxial anesthesia or peripheral nerve block. So with the protocols and guidelines, then we can communicate with the training of the nursing staff such that they can follow up the plan accordingly and give the patients relevant leaflets and the guidelines for certain surgical protocols. Just like if for the mastectomy, thoracotomy, or herniorrhaphy, and patients come in for orthopedic joint replacement. So usually some of the hospital, they already have the multidisciplinary team to formulate special guidelines for the patients and with the information leaflet, including the relevant regional anesthesia, such that the patients can be properly admitted with proper fasting and preparations with the consent to be admitted into the hospital. And then if for the day surgery, we can arrange the patient accordingly to facilitate early mobilizations and early oral intake. So the most important is that we can identify the high-risk patients for severe postoperative pain, and then provide the patients with educations, and then we can set realistic expectations with the patients. We have different tools recently come out to assess the risk of the opioid use. And this is very important. We have to take a proper opioid risk assessment, and then to formulate a plan as need. We can use the buprenorphine patch as an intermediate perioperative analgesia. There are many pain assessment tools we can use in the anesthetic clinic, including the physical pain diagram and the long mode anesthetic assessment with the medicine list and also the period record. But it's also important for particular high-risk patients, like for certain surgeries like mastectomy, herniorrhaphy, thoracotomy, who is known to have significant high risk for postoperative surgical pain. Then we may consider to give the patients to have some if pain inventory or some other pain assessment tools, like for the mixed pain syndrome with the ID pain and pain detect. For some patients who is known to be a chronic pain patients and also opioid users of complicated psychosocial history, which is at risk of anxiety and depressions, we can give the patient hospital and anxiety depression score or patient's catastrophic score to assess the risk for the surgery. If the patients are having high score, we will consider to give the patients some other pain agents before the surgeries or perioperatively. So it's very important to assess the patients before they attend the clinic or during the clinic, and then we have the nursing staff to teach them how to use the preemptive analgesia or how to continue the preoperative analgesic plan. So it's just a bit overview of the new classifications of ISP pain diagnosis. We all know that postoperative surgical and trauma-susceptible pain is classified as chronic pain, secondary pain. And having said that, we have known that a lot of patients, they have been having primary chronic pain as fibromyalgia, irritable bowel syndromes, migraine, and also some patients, they may already under surgeries because of metastasis cancer or different cancer conditions. So these patients, they need to be optimized and assessed to take a pain history properly before we proceed to the surgery. And as need as said, we should arrange this group of patients to have chronic pain clinic or refer to chronic pain specialists, or to admit the patient earlier in order to receive relevant consultations and to plan ahead before the surgery. So it's good to have a one-stop caring in the anesthetic clinic as a kind of multidisciplinary peer assessment clinic that we are now proposing in the transitional pain care. So we can have the nursing staff who have been trained to use different assessment tools for the patients. And also we can have certain assessment tools with people trained to test for whether the patients have any skin sensitization score with having sign of central sensitizations with hyperalgesia or allodynia. Although we know that there may be limitations of certain hospitals or in your country, you may probably have no such allied health or trained staff to do this. But if this is going into the past 10 years in the transitional analgesic plan and the guidelines in different countries. And it's very important for us in the assessment. We assess the patient whether they have nociceptive pain or they also, because of the surgical conditions, they have pre-existing neuropathic or visceral pain. This is one of the paper I have published with Rainer van Hagen about the concept of understanding mixed pain concepts. And this paper actually is getting more attention as people now using more of different pain assessment tools as a kind of and transitional pain preparations in the anesthetic clinic. This is one of the tools called Pain Detect that allow us to have a patient as a self-filling form to distinguish and calculate the score as an objective way for nociceptive pain and visceral pain and neuropathic pain. So the preoperative pain assessment is important that we, after evaluations, we can formulate a plan and then we can allow the patients to choose the options of analgesia. The patient usually, if as far as possible, we would like the patient to have regional anesthesia, which will be further elaborated by other speaker. So for us, assessing the patients, we would like to assess the patients of likelihood of experiencing severe postoperative pain, such as patients with opioid dependence, or the patients have history of chronic pain already on different multimodal analgesia. So it is very important to educate the patient the chance whether they have the post-surgical chronic pain status with complex regional pain syndrome or other post-surgical pain syndrome. And then we have the patient to set realistic expectations, and also we have to plan for the patient to opt as a kind of optimizations. Just like the patient already have some kind of osteoarthritis of knee and hip, the patient coming in for bariatric surgery, then it's important we involve the dietitians and other physicians involved, that whether we can medically using different medicines to help with the patients to decrease the body weight. And also we encourage the patients to have physiotherapy as a kind of muscle preconditionings and the physical strength conditioning before they having the real total joint replacement surgery or bariatric surgery. And we also would like to assess the patient psychologically to see whether the patient have any anxiety or the sleep problem. Comorbidity usually have depressions, anxiety, and also having the catastrophic thought. So it's good to involve some of the nurse have training with mindfulness breathing or some cognitive behavioral therapy, also to see the patients in the clinic and teaching them simple breathing exercise or some simple mindfulness technique. So the pre-anesthetic clinic is very important such that we can assess the patients apart from pre-existing pain, and we also would like to explore what types of the pain they are having, whether they have not pure nociceptive pain with orthopedic trauma pain or the patient have other surgical cause of cancer pain or other neuropathic pain status. So it's very important that in transitional pain service to prevent chronic pain syndrome, with the update and the real literature recently, it's very important we have total person assessment with the holistic approach. And then at best, we should use the multimodal analgesia such that we decrease the risk of non-steroidal anti-inflammatory drugs and also try to have opioid-free analgesic regime. And it's very important we also can discuss with the team, the surgical team, and then we come to a consensus with a subspecialty transitional pain service protocol. And for some of the visceral pain patients, it's very important we can assess them different pain type such that we can plan if the patient already have a lot of visceral pain and at risk of chronic pain syndrome, we will consider to offer the patients having the regional block or catheter, and also with if to see if any other coagulant and any contraindication for your axial block, and then we can consider peripheral nerve block as well. So the preemptive analgesia, including the schedule regular analgesic with oral or intravenous acetaminophen before the surgery, or during the surgery, we can give intravenous paracetamol, usually 1 gram, and then non-steroidal anti-inflammatory drug if the patient is not contraindicated, or the patient's have higher risk of GI bleeding, we can consider the use of COX-2 inhibitors, either to take orally operatively or intraoperatively. There is some arguments regarding the use of gabapentinoid drugs, but I also have done some meta-analysis remote and showing that actually the patients have better postoperative recovery scoring, and also the pain score decrease with the use of gabapentinoid. Although in different patients or different settings, there's some controversials regarding the use of it, because for pregabalin, there's increased water retentions and also increase in sedations in higher older age adults. We can consider the use of dexamethasone unless contraindicated up to 0.1 milligram per kilo. And that optional is the use of intravenous lidocaine and ketamine infusions as a kind of preemptive and to prevent the peripheral and central sensitizations. And recent guidelines for chronic opioid users in Americans by different societies also propose the use of intravenous methadone and also the use of buprenorphine patch to apply before the surgeries perioperatively, and to help with tide over the withdrawal symptoms in chronic opioid user. So the background analgesic we can use we can, according to the this analgesic diagram, we can block the peripheral nerve with the local anesthetic with regional anesthesia, and then we can also give the patients paracetamol, non-steroidal anti-inflammatory drug, or even intravenous alpha-2 agonist, desmetanide, or some central acting just like gabapentinoid, to as a kind of preemptive analgesia to decrease the chronic pain sensitizations. As we all know, if you have peripheral stimulations and there's central sensitizations peripherally and also centrally. So all these intravenous desensitizations, which have different levels of evidence coming into different guidelines by different societies and different college, and they all have different guidelines. And I think the lowest evidence is the intravenous nutritional or vitamin therapy, but this also have evidence and for the intravenous vitamin C, or is vitamin D therapy is also useful in certain conditions, just like to prevent the complex regional pain syndromes. So there's a revolution of the use of old drugs and with acute pain controls scientific evidence. So I'm not going this into details, but since we have possibly the use of this kind of drugs during the operations, we also have to discuss with the patients in order to get the consent. Because especially the use of ketamine, which have some psychomimetic effect, and also we also have to screen the patient medically any contraindications with the coma or increased intracranial pressures, or there's other risk of increased sympathetic response. So preoperative consultations and pain management planning for the patients with complex chronic pain is very important. And then we can have individualized the patients with anesthetic plan. And then we have important is to have communications within the teams of the surgeons and also the nursing team, such that we can have collaborations, and then we can co-join together to make patient information leaflet. Usually, for most of the hospital nowadays, they in orthopedic surgeons, total joint replacement, they usually have separate patients leaflet. And for patients having chronic pain, it's very important that we allow the patients the use and have enough stocking for them to take the existing medicines and the opioid. And then we have formulate a plan with discussions with the chronic pain physicians, the plan of titrations of the opioid as kind of extensive program, or as need consult the psychologist, psychiatrist, and social worker before the operations. So the aim is that we have to tailor-make the patients for the specific procedures with a specific plan. The target is that we have multimodal, non-opioid, and procedure-specific plan for the patients. The opioid should only be used when needed on the top of multimodal on non-opioid prophylaxis. And if we are going to use the opioids, we use that as a kind of patient control machines, limited to a few days, and then with the acute pain one by the acute pain team to titrate that into a longer acting medicine, which have less psychomimetic effect. And try to titrate with multimodal analgesics, with paracetamol or non-steroidal anti-inflammatory drug and gabapentinoid drugs or other psychological agents to minimize the risk of the opioids and the side effects and the abuse potentials. So we have the chronic pain opioid user with scoring system, and so I'm not going into details, but it's very easy for you to get it online with some of the American society. They're adopting this into their routine in the pre-anesthetic program, but this is not a routine in most of the European country and Asia countries. So the risk of opioid is that we may have perioperative withdrawal risk with the abrupt reductions of the opioids, and also with the opioid-induced hyperalgesia status. And so that's usually this state, most of the guidelines will advocate the use of brompheniramine patch, which is weekly patch in the form of 5, 10, 15, 20 microgram per hour to help the patients to tide over the withdrawal symptoms and also have a build up a background analgesic. So here is some of the common post-surgical pain and the patient with high-risk surgeries like mastectomy, thoracotomy, and then we can discuss the patient with different peripheral nerve blocks. And for patients having complex chronic pain syndromes, we need to formulate individual plans and then consult pain specialists. And then we have interdisciplinary collaborations with the pain educations. And intraoperative interventions will be further elaborated by other speakers, and I'm not going into details. But it's very important for us to aware of non-pharmacological psychological agents, including the use of regional anesthesia, and also we can have monitor anesthetic care with intravenous sedations, or we can have even with the regional anesthesia, we have to decrease the patient anxiety with intraoperative music, hypnosis, and guide imagery for patients with high pain catastrophic score and high anxiety score. So lastly, the most important is patient educations. It's very important you discuss with the nurse to have formulate a standard leaflet for the patients. And also we have leaflet for the regional anesthesia and with the risk with relevant diagrams such that the patients have realistic expectations and consent in the anesthetic unit such that we can pass on to our anesthetic colleagues regarding the use of ambulatory pump, different types of ambulatory pumps, and some of the countries or some of the setting they allowed the use of ambulatory pump to get home. Then we can show the patients relevant leaflet and diagram to teach them. All in all, pain is a total person's biopsychosocial model. So it's very important for effective acute pain relief. We must communicate with the team, we communicate with the patients, and then we aim for multimodal analgesia, opioid sparing, allow the patients have fast return of gut functions, allow oral analgesics, and then we have multidisciplinary collaborations and early amputations with the collaboration with physiotherapy, and allow the patient early discharge. Thank you so much for your kind attentions, and that's the end of my presentations.
Thank you so much, Dr. Carina, for your wonderful presentation. And now we will continue talking about the intraoperative guidelines in acute pain management, which will be given by Dr. Anna Schwartzman. Dr. Schwartzman is an anesthesiologist, an expert in pain medicine and palliative care. She also has a postgraduate interventional technique in chronic pain as an interventional technique for pain diploma, both acquired in Argentina and Uruguay, where she's from. She's a professor for the anesthesiology residency program. She's the actual president from the ESRA. She's a member of the pain committee for the World Federation of Anesthesiology Societies since 2020 to ongoing date. She's the coordinator in Uruguay for the Essential Pain Management Program from the World Federation, and she is the former president of the Uruguayan Society of the Study of Pain. She has multiple research interests, is also related to regional anesthesia, acute pain, and ultrasound application. Thank you so much, and welcome, Dr. Schwartzman, for your presentation.
Today, I will talk about the intraoperative period. I will outline evidence-based strategies to optimize intraoperative analgesia with a focus on multimodal approach, non-opioid strategies, regional techniques, and the critical importance of patient-centered outcomes. Pain control in the intraoperative period is not just about comfort. It shapes recovery trajectories, risk of delirium, development of chronic pain, and overall quality of life. Even with advances in knowledge and technology, pain remains inadequately addressed in many settings. Intraoperative period, it is not Las Vegas. What happens in the operating room does not stay in the operating room. It reverberates through the entire perioperative trajectory. Multimodal anesthesia integrates multiple pharmacological families to hit different receptors along the pain pathway. It is a customizable checklist rather than a rigid recipe, tailored to each patient and procedure. Multimodal anesthesia is not a fixed rule. It is a flexible, surgery-specific strategy. The objective extends beyond immediate relief to prevent central sensitization, and reduce the risk of persistent postoperative pain. Time is also important. Preemptive anesthesia has evolved from the theory to essential practice. Administering analgesics before the noxious stimulus improve outcomes compared with post-procedure administration. These include local infiltration, nerve blocks, epidural spinal blocks, and intravenous agents. First of all, we will highlight the importance of reducing opioid use intraoperatively. This is a central goal in our intraoperative management. Opioids carry well-recognized adverse effects that are not minor: sedation, dysphoria, delirium, constipation, urinary retention, and postoperative nausea and vomit. These effects can delay recovery and complicate the immediate postoperative period. Opioids pose life-threatening risk when mismanagement or in susceptible patients. Respiratory depression and airway obstruction remain major concerns in the intraoperative and early postoperative phases. Reducing opioid exposure supports faster recovery. Enhancing recovery after surgery, or ERAS, protocols increasingly advocate opioid-sparing strategies to promote quicker return of function, shorter hospital stays, and reduce resource use. Opioid-related adverse effects can prolong hospitalization and drive up cost. By minimizing opioids, we can optimize recovery and improve overall efficiency. Opioids may cause hyperalgesia and tolerance. Neuroadaptive changes can increase the requirements for longer-acting opioids postoperatively, especially with certain short-action intraoperative opioids. A multimodal non-opioid approach helps prevent escalation of postoperative opioid needs. There is growing evidence that opioids can modulate immune function. Opioid-based anesthesia may have inhibitory effects on cellular and humoral immunity, which raises theoretical concerns about cancer recurrence in the long term. While more research is needed, this is another reason to promote opioid sparing. Talking about the public health context, patients discharged with opioid prescription postoperatively are at higher risk of developing dependence. Some patients groups stand to particularly benefit for an opioid-sparing or opioid-free approach, such as those with morbid obesity or obstructive sleep apnea, where multimodal anesthesia and regional techniques can maintain anesthesia while avoiding opioid-related harms. A multimodal strategy is the key. By combining non-opioid adjuvants and regional anesthesia, we can achieve effective anti-nociception across different pain pathways, allowing meaningful reduction in opioid use without compromising hemodynamic stability. We'll survey key non-opioid actions used in multimodal regimens. The critical question is not just pain scores or opioid sparing, but outcomes that truly matters to the patients. In this publication, Barrett and colleagues highlight a critical gap. Most trials focus on surrogate endpoints. Only about a quarter use patient-centered outcomes as a primary endpoints. Dexmedetomidine, systemic lidocaine, and COX inhibitors emerge as more promising. Gabapentinoids and ketamine are less consistently beneficial. Importantly, many trials lack protocol registration, raising concerns about selective reporting biases. Starting with gabapentinoids, the GAP study published in 2025 is a pivotal randomized trial in major surgeries. Adding gabapentin did not shorten hospital stay, reduce serious adverse events, pain or quality of life, and surprisingly was associated with higher pain at 4 months. This challenges routine gabapentinoid use in multimodal regimens for major surgery. Intravenous lidocaine represents a paradigm shift. It provides analgesia and anti-inflammatory effects via sodium channel blockade. Recommended dosing allows substantial analgesic benefits, but note, this use is off-label in many cases despite the strong evidence. Dexamethasone serves dual purposes, antiemetic and anti-inflammatory, and is increasingly integrated into multimodal anesthesia. Optimal analgesic dosing is still being explored, but its inclusion is common in comprehensive strategies. Ketamine's MDA receptor antagonism offers a mechanism to prevent central sensitization and potentially reduce chronic post-surgical pain, especially when dosed perioperatively. However, regimen details and patient selection matter for balancing benefits and side effects. Burns' landmark study centered in variability of intraoperative opioid use. They analyzed over 1 million surgeries across 46 U.S. hospitals from 2014 to 2020. It shows substantial variation in intraoperative opioid dosing that cannot be explained by patient's factors or procedure types alone. Standardized multimodal anesthesia and ERAS-like protocols with data-driven feedback can harmonize practice. Variation in opioid use impacts patient safety, recovery speed, delirium risk, and longer-term outcomes. To improve care worldwide, we must address not only patient factors, but also clinician practice and institutional policies with adaptable evidence-based pathway. The impact of regional anesthesia in perioperative period could be a whole conference, but I will highlight that neuroaxial and peripheral nerve blocks help reduce pain scores in the first 24 to 48 hours and lower opioid consumption, which can lessen nausea, vomiting, and sedation. The choice of techniques depends on surgery type, patient factors, and available expertise. Neuroaxial anesthesia is great for thoracic and abdominal major surgery. Continuous catheter can extend anesthesia but require hemodynamic monitoring and skill management. Peripheral regional blocks are highly effective for orthopedic surgery in the extremities. Single shot versus continuous catheters offer flexibility and pain control and rehabilitation. Facial plane blocks evidence is growing. In a multimodal approach, combining regional techniques with systemic anesthesia yields better pain control and faster recovery. Implementation requires surgery-specific, individualized multimodal protocols, early preemptive strategies, prioritizations of patient-centered outcomes, and robust protocols help reduce variability and improve outcomes across specialties. Prospect guidelines are a good example of this kind of guidelines. We must address critical gaps, long-term outcome data, standardized patient-centered measures, and mechanistic understanding of unexpected findings. Aligning research with patient priorities enhances relevance and adoption. We should adopt standardized outcomes and involve patients and clinicians from the outset. To take home, we must prioritize patient-centered outcomes, implement surgery-specific multimodal protocols, be cautious with gabapentinoids, use promising non-opioid actions and regional techniques, and address practice variability to improve patient outcomes globally. The intraoperative window is a powerful moment to improve perioperative outcomes by embracing evidence-based multimodal strategies, minimizing opioids responsibly, and prioritizing patient-centered endpoints. We can advance global perioperative care. The future of intraoperative anesthesia isn't merely about reducing opioid consumption. It is about creating a seamless continuum of care that transforms the surgical experience from one of suffering to one of healing. These are the references, and we hope to see you all soon in Marrakesh in World Congress of Anesthesia. Thank you very much for your attention.
Thank you, Anna, so much for your wonderful presentation. Now we will move on to Dr. Eleni Moka's presentation. It would be about postoperative pain protocols. Dr. Moka is board certified senior consultant anesthesiologist in Greece. She trained in regional anesthesia, pain therapy, and palliative care, and also in cardiothoracic anesthesia. She also has a PhD in medicine and a master's in healthcare management and pain therapy. She is an ESRA diplomat from 2013 to 2019. She is the actual ex-ESRA president. She also was an ESRA board member and council from 2018 to 2022. She also served as ESRA Hellas vice chair from 2011 to 2015. She's the head of the anaesthesiology department in Creta InterClinic Hospital since 2004, and she has a lot of multiple research interests and related to regional anesthesia, acute pain management, and ultrasound applications. Thank you, Dr. Moka, for being with us, and we'll leave you for your presentation.
Thank you, Sidonia. Good afternoon or good morning. I don't know. Can you see my slides, first of all? Can you see?
We can see your slides, Dr. Moka.
Okay, fantastic. Hello to everybody, and welcome to this wonderful webinar that is taking place today with the initiative of the WFSA. It is very important that we finally sat together to discuss how we can optimize the surgical outcomes, not just in general, but through evidence-based acute pain management protocols across all the perioperative stages. And my talk is about, after the nice lectures of Carina and of Anna, to discuss what happens in the post-operative phase. And to be honest with you, I believe it's very important to start from some fundamental if I may say, some important conclusions, fundamental conclusions. Why? Because acute perioperative pain, I dare to say, is a silent epidemic. Why? Because the inadequate postoperative pain control, unfortunately, is the rule rather than the exception. And I can only echo what John Bonica, one of the fathers of pain medicine, has stated back in 1990. He said that for almost 30 years back at that time, he had been studying the causes of inadequate management of perioperative pain. And each time he arrived at the same conclusions that we also arrive today. That over time, the most important causes, unfortunately, remain the same. The inadequate or incorrect application of the available information and the unsuccessful adoption of the available guidelines and therapeutic techniques, usually due to lack of organization, due to lack of structured services, or even sometimes due to lack of available monitoring for our patients. And this is something extremely sad. But even something else that we should not forget, that as an anesthesiologist, we often say that okay, one size fits all. This is not the truth because there is an interpatient variability in the analgesia requirements among our patients. Not all of them are in the middle of this curve, but we can have outliers, we can have extremes, like with elderly patients or with obese patients, with children, and we often forget that, and this could be a reason for not achieving our goal for an optimum postoperative pain management. And as such, the perioperative or postoperative period can be truly challenging for all of us as clinicians. Why? Because 80% of patients undergoing surgery, unfortunately, even nowadays, experience postoperative pain of any type or of any severity. Less than 50% report adequate pain relief, and of those that are not relieved, 88% can have moderate, severe, or extreme pain. In addition, 1 in 10 of our patients can develop chronic post-surgical pain, and from those, 2 to 10% will have chronic pain after surgery that is extremely severe or even refractory sometimes. And the most striking is that pain, postoperative pain, accounts for almost 40% of unanticipated admissions and readmissions following ambulatory surgery, surgery that is done to facilitate the mobilization and the recovery of the patient. But because of the pain, unfortunately, this recovery that we targeted is not the case. And if we look further to the broader picture of the problem and what are the consequences when we do not manage correctly the acute postoperative pain after the surgery is over, according to the Institute of Medicine and this publication, the Blueprint for Transforming Prevention, Care, Education, and Research that appeared in literature more than 10 years ago, we can see that unrelieved acute postoperative pain results in impaired physical function of our patients with reduced mobility, disturbed sleep, or immune impairment, in their dependence on both medication but on their family members and other caregivers, in an extended recovery time with multiple readmissions, an increased risk for developing persistent post-surgical pain, all of those having economical cost for the healthcare systems, the patients, the society in general, and definitely a negative impact on the quality of life of our patients. And this is why this is something alarming in my opinion, that necessitates a call to action. How we are going to apply the available recommendations for immediate postoperative pain relief, starting from the PACU, going on to the ward and to the post-discharge period, how we can apply postoperative opioid-sparing strategies, and what are the rescue analgesia pathways that we have in our hands, remembering that even if regional anesthesia is a standard of care in many of our operations, still there is the risk for rebound pain. How we are going to monitor our patients for both the pain or the respiratory depression post-surgery, how we are going to optimize the ERA's recovery pathways, and finally, what is the role of acute pain services, what is the status today of transitional pain care, and how all these can be implemented into the broader concept of precision medicine. As far as postoperative pain management, I will not focus a lot because we have heard many information from the previous speakers. I think the most important that has an impact in the postoperative course of our patients is the careful and correct planning. We have multiple pharmacological analgesia medications in our hands. We have heard them, how they can be applied in the intraoperative period, but they can be continued postoperatively. These include the paracetamol, the NSAIDs, the opioids, balancing, of course, the analgesic effect against the side effects, and of course, many adjuvants for which we have heard a lot of information some time ago from the previous speakers. Certainly, regional anesthesia and analgesia, either with peripheral blocks or with the central neuraxial techniques, are a very important tool in our armamentarium. And all of those can be applied via a modified WHO pain ladder according to the type of pain we have, the severity, and of course, some of them can be given regularly at timed intervals, and some other as required or according to the peculiarities some of our patients have. About prospects, these are guidelines that you have heard before from Anna Schwarzman, and it is true that every year this group, that is an ESRA group, produces 6 to 7 procedure-specific guidelines and recommendations on various types of surgery like colorectal, spine, thoracotomy, thoracoscopic, sternotomy, and so on. And it is very interesting that now we have those information available not only in publications, but also in very nice infographics that by one look can give you the information that is needed for your daily practice. What is important is to remember that in the postoperative or the overall perioperative period, there are specific rules that need to be followed. I will not speak at all about the preoperative assessment, as Dr. Carina Lee already talked about it. However, I will speak about the immediate postoperative period in the PACU and later on in the ward, because the goals of the pain management there needs to be matched to the type of surgery, but also to the stage of the recovery. And our strategies must promote the return of normal function of our patients with the avoidance of new modified release opioid use due to the risk of harm. And what is also important after the end of surgery is that we need to follow a pattern of decreasing the analgesic needs of our patients. What we need to follow is the reverse of the WHO analgesic ladder. And opioids should be weaned first, with NSAIDs being followed, and then finally paracetamol to be the last. It's not only what happens in the ward or in the PACU. We need to be careful about the post-discharge period and what we need to do just before discharging our patients from the hospital, because education of our patients is extremely important, specifically regarding the self-administration of opioids. A hospital discharge letter is mandatory to clearly state the dose, the amount of the drug that is supplied, and the duration of any prescribed opioid. And recommendation for a medicines review after discharge is absolutely necessary. And in the post-discharge period, we should reassure that there is support for safe disposal of unused opioids at a community pharmacy, for example. Postoperative opioids must not be added to a repeat prescription, and opioid naive patients, which is extremely important, and who are still on long-term opioids, even including tramadol 3 months post-surgery, should warrant further review in primary or in secondary care. And if we focus a little bit more to the PACU and the ward and how we deal with postoperative pain management and what pathways and strategies we should follow, I think it has been heard already. It comes from the Faculty of Pain, from the Royal College of Anaesthetists. We need an holistic assessment of pain in the recovery. We need to optimize the pain levels before discharging our patients from the PACU. The aim is for improving pain-related functions and to use, if necessary, immediate release opioids and not slow release. our target should be to manage the opioid transition to primary care and not to administer opioids after 7 days post-surgery. About the goals, we have to remember we need a team, the surgeon, the anesthetist, all healthcare professionals, because we need a seamless transition of analgesic care from the operating theater via the recovery to the ward. The goals of our management should be matched to the surgery, to the stage of the recovery. For example, in a laparotomy, the immediate goal is the ability to cough and breathe deeply, but in subsequent days is to facilitate the mobilization. So we have various aspects of what we are targeting about. And it is important to assess correctly the postoperative pain. And the reason of assessing properly the levels of pain and how these are perceived from our patients is because we want to promote the return to normal function, meaning drinking, eating, movement, and mobilization. We need to optimize the pain relief before leaving PACU, and this should take the function into account. A pain assessment that involves the functional assessment, not only the pain, but the breathing, the mobilization, the capability to move, to stand maybe in some cases, is extremely important, also taking into consideration that anxiety of our patients can increase the patient perception as well. We should not forget the pain in surgical patients in specific circumstances, and we have heard about the opioid-dependent patients, so I will not focus too much on that. However, we should not forget the acute neuropathic pain after surgery, because it can happen when we have traumatization of nerves, for example, like in limb amputation, and their preemptive analgesia with RA, with ketamine, with blocks can be helpful. We have to be suspicious with a high index of suspicion for these patients at high risk, and we can apply treatments that have been extrapolated from the chronic neuropathic pain cases. As far as the ward, we know that we need the normal function, and all of us said it. We should focus to oral route of all our medications, the analgesics. It must be realized that increased pain intensity could not be only because the patient has a problem with analgesia, but could be a consequence of surgical complications. And we should not also forget the sedation scores that should be recorded in addition to respiratory rate and all the other vital signs. We want optimal analgesia after surgery. It's in the ERAS protocols, in the PROSPECT protocols, in multiple guidelines, because by optimizing analgesia, we can have the comfort of our patient, the fastest functional recovery, and the fewest side effects. And it is this mnemonic word, the DREAMS, drinking, eating, analgesia, mobilizing, and sleeping, that we should always remember in any type of surgery we are participating as anesthesiologists or perioperative care physicians. And since we discuss about functional recovery, it is true that it is something very much highlighted in literature lately, especially in relationship to regional analgesia. And cases of orthopedic surgery like knee arthroplasty, that is among the most painful ones. We have to remember, though, that achieving a great functional recovery is not easy. Why? Because the perioperative period is extremely complex, and because the definition of functional recovery is not consistent. What is it? Is it only ambulation? Is it procedure-specific functional recovery? What is more important? Clear answers do not exist because we have a variety of outcomes that are self-reported by the patients, but also performance-based. And also the timing is something that is also remains also controversial until today. However, since we discuss about functional recovery and TERAS and regional anesthesia and pain management, I think this is one of the most nicest infographics one can see in literature by the group of Steve Coppens. It is related to regional anesthesia and analgesia techniques. However, there is no evidence supporting a superior block. The appropriate block for our patients that we will continue with the catheters and the pumps in the postoperative period is patient-specific and procedure-specific. And why there is no evidence for a superior block? Because there are other factors surrounding the perioperative phase that unfortunately are more important than the regional analgesia itself. They have to do with the patient, the expectations of the patient, the transitional pain care that I will say a few words later on, the multimodality of the analgesia we do, the counseling, the limiting of the opioids in the postoperative period, the non-pharmacological techniques that can be applied, and all those elements that target the patient comfort in the immediate and longer postoperative period. And in this context, since we discussed about sparing the opioids according to this nice publication of the group of Carina El-Bogdadli from the UK, again, they speak about the reverse analgesic ladder and the functional recovery. And what they propose that the drugs that we should give to our patients at discharge should be paracetamol and NSAIDs if not contraindicated. We should give opioids of immediate release for a limited duration and avoid the long-acting ones because we want patients to stop receiving opioids to promote their function. We avoid compound analgesics as they hinder deep prescribing, and we certainly give advice to our patients post-discharge to try to stop the opioid, to continue with simple regular analgesics in an effort to return to the baseline function with all the postoperative analgesics stopped. And it is true that in the perioperative care setting, there are modifiable risk factors like those in the immediate postoperative period or inside the ward during the hospitalization. Because we forget to modify the opioid dose, we continue the infusions for more days than needed. We initiate long-acting opioids because of lack of knowledge, lack of training, lack of team. Sometimes in elderly, we administer sedatives, which is not correct. And most importantly, we rely on unidimensional pain scores alone, which is not the reality. We should emphasize on the patient-reported outcomes and not just the classical VAS scores. We need scores that are more dynamic and take into consideration all the aspects of the perioperative care continuum. And of course, for all the things that we don't do correctly, easily, there are recommendations, as you can see on the slide, that we can apply and we can improve the outcome of our patients. And even if we stop the analgesia or we decrease the doses, there is always the case that the pain will exist or will become higher because of the patient pain trajectories or the procedural pain trajectories. And as such, we need a rescue perioperative analgesia plan. And it starts with the preoperative analgesia use and the preoperative pain baseline, the examination postoperatively of our patient, the assessment of the severity of the pain, the determining of what type of pain we have, and definitely according to the various guidelines, the administration of the appropriate rescue treatment. And just to close my lecture, I think that we have the acute pain services, but we have moved further, and the future in the pathways of care is the transitional pain services that have started from Toronto in Canada by a group, by a team of people, a multidisciplinary team, by anesthesiologists, acute and chronic pain specialists, nurses, psychologists, physiotherapists, patient care coordinators, a group of people that take seriously into consideration an holistic approach of pain experience involving psychological, biological, behavioral, and sociological aspects. The goals are the optimal acute postoperative pain control, but also non-pharmacological intervention and psychological therapies to be applied. Why? Because the patients do not only have pain, they have anxiety, they have postoperative stress, they need education, they need cognitive and behavioral therapy, they need physiotherapy, and not only multimodal analgesia and a judicious use of opioids. And it seems that these transitional pain services can help even in decreasing the percentages of chronic post-surgical pain, because the TPS is probably the missing needed linkage and a soft place to land for patients at high risk for long-term excessive opioid consumption and for chronic post-surgical pain development. In order to establish them, we need some key principles like early intervention, multimodality, regional anesthesia, and analgesia. We need a structure with a team to stratify and put the patients in categories according to the risk, to apply the immediate postoperative pain management, but also to follow up the patient upon discharge, and of course to keep in mind the dedicated core outcomes, as you can see in the slide. In other words, we speak about an integrative care model that starts from the preoperative phase but continues even after 3 months post-surgery. We identify the patients at risks and educate them, including their caregivers. And we realize that just multimodal analgesia or a good analgesic plan or guidelines or regional anesthesia are not enough. There are so many other parameters that have to be taken into consideration for improving the outcome and the recovery of our patients. And since we discuss about modern medicine, let's not forget the pharmacological prevention of pain or the prevention of postoperative pain in general in the context of precision medicine. Precision medicine is a new era in medicine, as you all know, that takes into account the individual differences of people's unique biology, environments, lifestyle, empowering patients, researchers, and providers to work together towards development of an individualized care. And it is obvious that this precision medicine section is probably a case of great expectation. And if we apply this precision medicine model in the postoperative or perioperative pain management, we can easily understand that we have moved certainly from the one-size-fits-all medicine to stratified medicine, where patients are subgrouped by their pain subtypes, their risk profiles, their demographics, the socioeconomic status, the clinical features, and so on, and even further to the individualized patient level, taking into account genomics, proteomics, again, lifestyle, health history, medical records, compliance, and exogenous factors. And if I would like to close, I would say that the key message from my side is, yes, we have guidelines, we have recommendations, we have a lot of strategies available in our hands. We need to learn how to use them in the most proper way and how to apply and deliver to the right patient, the right analgesic at the right moment for the right procedure. And I would like to thank you for your attention and also invite you to the 3rd edition of the World Week and World Day of Regional Anesthesia and Pain Medicine that will take place next January as an initiative of ESRA, organized together with all our sister societies. Thank you very much.
Thank you, Eleni, so much for your wonderful presentation. As we end the part of the guidelines, we can see that all of the information that we're sharing has all of the techniques that that our panelists are talking about are accessible to all of the patients. So it's important that we can learn how to use them and how to combine them to give a proper management for acute pain in our patients. The next panelist is Dr. Francois Retief. He is from South Africa. He's a consultant anesthetist and senior lecturer at the Tygerberg Hospital in Stellenbosch University in Cape Town, South Africa. He's the head of the clinical unit of the pain medicine, a coordinator of the postgraduate anesthesiology training program, chair in the South African Society of Regional Anesthesia, and treasurer of the African Society of Regional Anesthesia and Pain Therapy. Also in research interests related to anesthesia, acute pain, and ultrasound application. He's going to talk about the new technologies that we can use and apply for acute pain management. Thank you, Dr. Retief. We're waiting for you.
Thank you, Sidonia. And Eleni and Anna and Carina, thank you so much for your excellent presentations. I think there's little left for me to say. I have a little bit of a complicated setup. There we go. I have nothing to disclose. What new technologies are implemented in acute pain management? I must say I'm a bit thrown in the deep with the topic since I have to talk about some technologies that I do not have experience with. So I'm going to try and demonstrate something here. Why do we need technology? Can everyone not just follow the guidelines? I'm going to demonstrate, so bear with me. So before surgery, we do a block and give basic analgesics, and pain is well controlled during the procedure, and afterwards pain is controlled so the patient doesn't ask for additional analgesia. And then in the middle of the night, the block wears off over quite a short period. Literature shows that patients wait until pain becomes unbearable before asking for analgesia. And then they think it's going to be given immediately and it's going to work immediately. So the patient gets the analgesia, takes 30 minutes to give it, 30 minutes before it starts working, and the patient have an episode of rebound pain. Analgesia is given, which controls it to some degree, but it wasn't enough, and the patient get another dose. Then the pain is controlled. The patient start mobilizing, get physiotherapy, the drugs wear off, and the patient get another bolus. Now we overshoot, and we have opioid side effects. And so it goes. If we did not do the block, or the block failed, we would have given this a simple analgesics and opioids, but blood pressure and heart rate is not reliable for judging intra-op analgesia. So we may give too little. Patient wakes up with severe pain in recovery, and then we give opioids, overshoot, and the opioids peak in the ward, and we have opioid side effects again. So this scenario may continue for days, sometimes for weeks for some patients or procedures, ultimately leading to increased stress response and poor patient satisfaction, cardiovascular and pulmonary morbidity, long hospital stay readmissions, delayed mobilization and rehabilitation, chronic pain, and opioid dependence, as the other speakers have alluded to. What I'm saying is that multimodal analgesia, in addition to being the use of different modalities to act synergistically and minimize the side effects, it also has a component of chronologically planning the analgesia to make sure that analgesic modalities overlap to prevent these time points when there are gaps in the analgesia. The problem is that we cannot accurately predict each patient's pain. If we know the pain is going to be at 7 o'clock, we can give all the other drugs at 6:30. But the responses of patients are different, and we depend on the patient to tell us when rescue analgesia is required. So what do we want from technology? Firstly, we can do with ways to make nerve blocks be better and safer and increase their availability. It would be helpful if blocks can last longer and be titrated over to cover these gaps in analgesia. We would like to be able to measure pain objectively and also be able to predict when patients are going to have spikes in pain and manage them timely. We need more and better analgesic modalities to prevent overuse of opioids. These also include supplementary modalities to give patients options and control, to manage pain and anxiety and improve recovery and rehabilitation. And we need assistance in analgesic resource allocation. So in other words, which patient should get the resources, needs the resources. So improvements in availability of ultrasound and in cost and quality has led to numerous blocks being described the last 10, 15 years. Ultrasound-guided regional anesthesia today plays an invaluable role in acute pain management and in both in painful procedures and in ambulatory surgery. A decent quality handheld probe now costs about $2,000 to $3,000. Considering the improved safety, performance time, onset duration, protection against local anesthetic toxicity, and the fact that it can be used for other things like POCUS, I would argue that ultrasound is not optional, even in a very low resource setting. Needles have improved echogenicity due to uneven surfaces that scatter the sound. And then some ultrasound machines and systems have needle path prediction and needle visualization or guidance using things like electromagnetism or beam steering and artificial intelligence. The big new thing is, the big new thing is augmented reality overlays on ultrasound machines. And I guess this will probably be standard on most machines in the next few years. It is currently around 93% accurate, which is better than many providers. The artificial intelligence model trains on thousands of images and can follow structures three-dimensionally as you scan through the tissue to help and identify the structures. A current concern in my view, is the risk of overdependence on artificial intelligence. If I am 93% accurate, I will usually know when it's one of the 7% of cases where I am unsure. But if I just trust the artificial intelligence and I'm not sure, I'm not going to know that it is one of the 7% where the artificial intelligence is wrong. Modalities to extend block duration. So the gold standard is perineural catheters. It's like epidural that you put around the nerve on the ultrasound with elastomeric pump. Advantages of catheters are that they are titratable over extended periods, but they are cumbersome and they have many complications. So it's not always possible to leave them in or to send patients home with them. Newer technology utilizes catheter over needle systems, which is like an IV, and small programmable pumps that has remote control and allow programmed boluses and patient-controlled boluses. And some incorporate artificial intelligence calculations and control, which means they can give a much better and more tailored analgesia. Other ways to extend the duration is extended release local anesthetics. So liposomal bupivacaine is supposed to release the bupivacaine over 72 hours. According to recent meta-analyses, it does work, but the clinical effect is small. It's 0.9 on average on a scale of 1 to 10. It decreases pain at 24 hours and 0.7 at 48 and 72 hours. There are other nanotechnology analgesics like Zainrelef, HTX-001, which is a mixture of meloxicam and bupivacaine in a polymer, which does the same. It looks very promising, but currently it's only for wound infiltration. Additives like dexamethasone and dexmedetomidine and epinephrine, they extend the duration of blocks, but I think more importantly, they expand the period over which the block wears off, giving us chance to administer systemic analgesics in time. There's chronic pain modalities that has been utilized for acute pain. Cryoneurolysis used traditionally for nerve ablation in chronic pain conditions, is suitable for acute pain. Handheld devices are available. It's got a mechanism much like a fridge. It's got a CO2 or nitrous oxide canister, which blows under pressure the gas into the tip where it gets released, and that cools the tip down to about minus 40 to minus 60 degrees. The freezing causes Wallerian degeneration, similar to a type 2 nerve injury, where all the endoneural tubes or sheaths are intact. So when the nerve regenerates, the axons go down the correct pathways and you get full recovery. So the block lasts anything from, depending on how well you do it, 2 weeks to around 3 months. So it depends on mostly on the actual freezing temperature and time. Cryotherapy was initially used for knee arthroplasty in patients with chronic knee pain. It's also been used for rib fractures and for breast implantations and other surgeries in patients with chronic pain disease, conditions where you need a long-lasting block. A new experimental intervention is injection of an ice slurry next to the nerve. The slurry contains glycine, which decreases the freezing point, much like antifreeze. So you can inject it at around minus 10 degrees. It's probably cause a block similar to neuropraxia, where the axons are still intact, but only the myelin is damaged. Safety data looks very good on rats. I don't think it has been used on human yet. Cryoneurolysis is generally specific for myelinated fibers, but it would usually be used only on sensory nerves. Then neuromodulation. Peripheral nerve stimulation is a type of neuromodulation like spinal cord stimulation. Anna knows much more about this than I, so if you have any questions directed to her. It works via the gate control theory or lateral inhibition by stimulating motor fibers and thereby inhibiting conduction of pain. In addition to analgesia, it seems to decrease progression from acute to chronic pain. Of course, transcutaneous electrical nerve stimulation, TENS, works on the same principle and is an established adjunct in both chronic and acute pain, which patients can use as they require it, like a PCA. It is also now available as an over-the-counter device for patients in some countries. Sorry, there's the slide. Okay. As we heard, all patients are different, and therefore we need to titrate analgesia differently. The WFSA had an excellent webinar last night on biological differences, psychological differences, beliefs regarding pain, and patient needs and priorities. Intraoperatively, blood pressure and pulse rate and signs of sympathetic response are not reliable enough to judge intraoperative nociception. We often get it wrong and the patient wake up with pain. This has major consequences. If the patient wake up without pain, and without opioid side effects, the patient realizes that he or she is okay. And they start to mobilize, and that prevents muscles from getting stiff and going to spasm, which aids analgesia. They move more and mobilize quicker. It decreases their anxiety and contributes to anxiety, which contributes to pain. And later, when the pain comes, they realize that this is abnormal, and then they ask for analgesia in time. Recently, several objective nociception monitors became available. The most studied one is this one, the nociception level index. It uses plethysmography for heart rate and heart rate variability and pulse variability, skin conductance for sweat as a symptom of sympathetic outflow, and temperature and movement. We give a number between 0 and 100. Below 25 indicate sufficient analgesia. There are other similar monitors as well, and some are based on recognizing EEG spectral patterns or ECG or pupil changes that are associated with nociception. So anxiety and focusing on pain plays a big negative role in postoperative recovery. Therefore, distraction and relaxation techniques have been shown to have analgesic effects. Virtual reality is one that received a lot of attention in recent literature. Moderate reduction in pain and anxiety have been shown during and up to 4 hours after a session. It is a type of on-demand distraction that the patient can regulate, and it is relatively cheap and can be managed from a cell phone. All right, there are several digital health tools available and in development. Initially for chronic pain, like Curable and Manage My Pain, and now also several for acute pain. In its most basic form, it can be used for patient information and education. It can be used to track patients' pain and reporting and other symptoms, and for communication with healthcare system. There are also apps that use face recognition to measure pain. Apps save a lot of time, allow ambulatory tracking, and ascertains that each patient receives all the information that is required. Wearables like smartwatches and wristbands are integrated with some systems. It measures vital signs, movement to track rehabilitation, sympathetic activity, sound, and so on. When AI is integrated, artificial intelligence is integrated, it can use information from health records and tests and combine that with data from the wearables and feedback from the patient to predict pain episodes and create tailor-made personalized pain management plans. Closed-loop systems are then possible, where analgesia can be managed by the AI, as well as anxiety and activity and other aspects of rehabilitation. Also, a lot of water have to run into the sea before this will be practiced. So, in summary, there are several new technologies helping with specific caveats in our clinical practice. If technologies are not available, it doesn't mean you can do nothing. There are for each a simple traditional technique as well. For nerve blocks, ultrasound and additives and regular multimodal analgesia is good. And as a last resort, wound infiltration should always be recommended. For neuromodulation, TENS is not expensive. And I think probably touch and physical activity should have similar effects. Monitoring for breakthrough pain, patient education can have good outcomes and can give you good information. Virtual reality is not expensive and can be done from a cell phone, but music or video games or mindfulness will also help. And then digital health systems, simple use of a cell phone, apps, and even just text messaging to follow up on patients would be a good start. So according to a recent survey by the Prospect Guidelines, less than half, I think something like 30-something% of participants are following all the evidence-based guidelines. And according to other studies, and I think in clinical practice, you see that very few patients are actually getting everything that's recommended. So none of these technologies are a magic bullet. We first have to do the basic things right. Thank you.
Okay, thank you, Dr. Retief, for your wonderful presentation. So now we would move on to the questions and answers section. If you have any questions, you can write them in the chat so we can ask our panelists. To begin, I'll ask some questions so we can keep it interactive. Dr. Lee, are you connected? Okay, so Carina is away. Okay, so Dr. Schwartzman. So, Anna, are you there?
Yeah, I'm
Yes.
here.
Okay. Okay. So, which
Ask me.
multimodal analgesic combinations are most effective during surgery from your perspective?
You choose the most difficult one. I think as we have been talking today, not one size fits all. We have to take into account the patient, the surgery, and then choose which strategy will be better for this patient. If we talk about evidence, we know that lidocaine, especially in abdominal surgery, it has very good evidence, the lidocaine intravenous infusion. I think it will be always present. And concerning to alpha-2 agonism, especially with dexmedetomidine, we have also good level of evidence. Someone asked in the chat about magnesium. I want to say two words about magnesium. Magnesium has not strong evidence for its use intraoperatively. As you know, magnesium could prolong muscular
No.
relaxation and have some cardiovascular effects, but it could be used. The magnesium is also another tool. In my practice, I always use lidocaine IV, and I use a lot of ketamine. I love ketamine because I think it is a very good desensitization agent. And I know how to use it in order not to have the psychomimetic effect. That is the one that we all are afraid of. But I think ketamine is a very good coadjuvant, and also lidocaine. And with these two things, almost every patient could be well managed. But again, we have to adapt our knowledge to this patient, to this surgery, and even to the place where are we working, because as you know, this is a worldwide webinar. We don't have the same drugs in the same hospitals, even in the same clinics, more in the same parts of the world. But this will be, I think that always we have to add some anti-nociceptive agents, some desensibilization, as Dr. Carina explained us very well.
Okay. Thank you, Dr. Schwartzman. Dr. Lee,
Yes.
so what are essential elements of a preoperative pain risk assessment for you?
I think it's the holistic total person assessment. So it's like, I think it's important to ask the patient any past history of chronic pain, or whether the patient is taking regular opioids or any other mood agents like comorbidity. How was the sleep of the patients? And it will be good actually for some of the patient or some center actually they use standardized beef pain inventory because that actually have a pain diagram in it, and also it asks about the sleep. I would say this is a good assessment to use for patients having major surgeries, or for surgeries like mastectomy, thoracotomy, or trauma surgery at risk of post-surgical pain. Then we can assess on the patients as a kind of self-filling type of questionnaire, such that when we see the patients and we review the medical history, the medications history, and then to dig in. Yeah, we have after COVID, or some other, like people having more, in the community having higher preference of anxiety and depressions, and patient using like soft drug recreation drugs. So it's very important to ask general questions like how was your sleep and how was your mood, whether you are taking serotonin drugs. Because a lot of patients these days, they are really taking hypnotic and serotonin drugs, especially after COVID, as we are aware that increase in fibromyalgia preference as a kind of secondary fibromyalgia with the mood affected. So I think that is something important to ask in the clinic as well.
Okay, thank you. Dr. Moka, what do you think are the most common errors in post-operative analgesia, and how can we help in avoiding when it happens?
The common errors.
Yes.
The errors are simple. We have so many drugs, so many techniques, and so much knowledge that is available in literature, but we forget to apply. This is the common error. I would say the most important thing is that after recovery, we forget sometimes to evaluate the pain levels of our patients in the ward, and we even forget to include the patient-reported outcome measures in our evaluation. There is a fully busy hospital, a lot of patients coming and going. We forget to create teams that could support us there. We need to train and educate nurses, for example, paramedical personnel, to learn, support us in simple things. And by this way, we can be informed what is the patient that has a problem and we can go. But the team will review all the patients. Another failure is that even if we use catheters for regional anesthesia, analgesia, central, peripheral, whatever, PCAs, don't be surprised that there are reports that we forget to start the medication. It's a matter of continuity of care inside the hospital, and this is why we need the APS and the TPS later on. And some other times is the misuse of information that exists. When something new as a drug comes, it's not for everybody, it's not for all the patients. This is a kind of misuse in information. Plus, there can be device and operation errors with pumps that do not work, with, I don't know, machines that are not available or effective in their function. I believe if we learn to evaluate the pain of our patients, and if we create a team, all these small problems that sound small but are big could be avoided and help improve our practice.
Thank you so much for your answer. And I agree with you. I mean, in my country, we don't have automatic pumps, so we have to use elastomeric ones. And then we also have the difficulty that they don't infuse the quantity of PCI we need for the pressure to infuse the drug so the patient can have it. Or we have the opposite, ones that infuse the whole medication in an hour. So it's really hard to control.
We have the same problem.
Yes. So, Dr. Retief, which technologies that are currently, do you believe are the most accessible for clinical use?
most accessible.
Yes.
The older ones are more accessible. The ultrasound, good ultrasound, and perineal catheters, additives. Of the new things, PCI pumps are available, but the newer ones are quite expensive. While you're talking about, I'll answer the question now, but a big problem with the patient-controlled analgesia is that patients wait until the pain they can't bear the pain, and then they give analgesia. And then the old pumps can give it only at 1 milligram of morphine or whatever you give every 7 or 8 or 10 minutes. So it takes an hour or two to control the pain. And after the patient tried 3 times, they give up. So the new PCI pumps, programmable and with artificial intelligence, will make a huge difference, I think. So PCI pumps are available. Digital health apps are available. Most patients have smartwatches or cell phones at least. Nociception monitoring is available. The ultrasound with artificial intelligence is available. It's expensive still, but I think it will become much cheaper. Yeah. There's other, virtual reality is cheap. PENS is cheap and available. Yeah.
Okay. Thank you, Dr. Retief. Dr. Lee, so I'll make the final round of questions. I would like to know, how do you counsel patients regarding realistic pain expectation?
I will actually, because we see the patients in the anesthetic clinic, so after assessment, I will discuss with the patient's options of analgesia and then the options for the perioperative multimodal analgesia. So I think the important is that it depends on the types of surgery. Whenever there's possible regional anesthesia, then I will discuss with the patient the options of either, to do the operation solely under regional, or depends on the cardiac risk and respiratory risk of the patient as well, and the comorbidity of the medical conditions. And for orthopedic patients or some other, lower pelvic surgeries, then it depends on the patient whether it's fit for, liver axial block, such as solely as a regional anesthesia and analgesia. I think the most important part is to explain to the patients the two things can be separate, anesthesia, analgesia, because we have a lot of generalists. They always first think of general anesthesia, and then the pain part is only a peripheral nerve block. So actually, I think it depends on the comorbidity and the risk of the patient. We do have some patient very high respiratory risk. We will only do it as solely regional analgesia, anesthesia, but then with the patient very high anxiety, then we will give intravenous sedations. So options are many. So we basically it's best to work up with the surgeons and the team, the subspecialty team, to work our a easy protocol such that most of the other colleague or even the trainee and the resident can follow. And for special, chronic pain patients, then we will discuss continue their perioperative use of analgesic like opioids or pregabalin or whatsoever drugs, but we have to take care about the interactions of tramadol with serotonin drugs, which may cause serotonin syndrome. That is something I think is very important.
Yes, I know. We all have that problem. I think you ask a patient what type of anesthesia you want. I want GA, but I don't want to feel pain. So I think that is one of the basis of all of it. Thank you, Dr. Reed, for your answer. Dr. Schwartzman, so how should regional anesthesia be adjusted for prolonged surgeries? What do you think we can do?
No, the best thing is the catheter. This is the answer. if not a single shot, but a catheter to put a catheter is the thing that we can be sure we will be In the same time at the surgery last, we have the anesthesia. This is the only way. If it is a prolonged surgery, we will be sure if we have a catheter.
Thank you. Dr. Moka, so what would the ideal structure of an acute pain service would be?
The ideal structure to be multidisciplinary, multimodal, available 24 hours, every day of the week, every day of the month and of the year, with clear guidelines, because the guidelines exist that can be adapted according to local practice, hospital policy, availability of medication, of material, of instrument. We need education of our staff, of our team, on how to work all of us together, on how to approach the patient, to start from the preoperative phase in an integrated care model and continue up to 3 months, even post-surgery, if possible. It is expensive. And most importantly, with all these actions, we need a standardization of care. This is important. We cannot be in a hospital 20 anesthesiologists and each one of us to do something different. We should have protocols that should be co-decided by all of us. We need audits. We need interdisciplinary groups, and we need to prioritize in the team the evidence-based medicine. If we have common protocols, independently who is the anesthetist, patients will receive the same care that is co-decided and is evidence-based. And certainly we need also task forces that are multidisciplinary, also bringing new ideas, new issues. Audit is very important, extremely important. We can do it on a monthly basis, like a small talk in between us, why this and why that. And this can improve the outcome. And I think the future will be transitional pain services, for sure.
Yes,
It means that we need more money, but an easy way to do it is that utilize your acute pain service for the transitional care, because otherwise we cannot ask the hospital administrators to pay thousands of dollars and euros, etc. We can be more flexible, and being flexible means team approach, means multidisciplinary context and audit of our activities.
thank you so much for your answer.
I want
And
to
Dr.
add
Retief?
something. I want to add something. What Eleni said, very, very well, amazing, Eleni. That the variability of the use of drugs is very harmful. It's very harmful for the system, and it's very harmful for the patients. When we talk about protocols, I think that we think we are talking about a paper, and a protocol is an agreement of all the team that we are going to do all the same thing because it is the best for the patient. And these things, like I say, I use one drug, one dose, and you use one drug, is very, very harmful. And I think we did not realize how we can change this, that is a simple thing and low cost, and improve our results. Thank you.
And also something else, we speak about audit, and in every hospital there is an electronic medical record system, if I may say. If we use the data, if we ask our hospital to create about the pain or what we are interested in, kind of IT input there, we can have our data at the end, and we can audit and evaluate our actions and our initiatives.
Okay, thank you so much. We have reached the limit of time. It was a wonderful webinar. Thank you all for your compromise and for being here and for helping us deliver all the information we just discussed. And just to end this session, I would like to invite all of our attendees to the World Congress in Marrakesh. that will happen from April 15 to April 19. It's going to be a very nice meeting where we can share and have multiple areas of expertise in anesthesia delivered to all of you. So we hopefully invite you and wait for you there. And don't miss, like Dr. Moka said, the third day for World Regional Anesthesia Day, which we are also participating in. Thank you so much for all of your attendees.
Thank you. It
Thank
was
you.
wonderful.
Thank you
so much.
Congratulations.
Thank
That was
you.
fantastic.
Thank you all.
Bye.
Thank you. Thank you all. Bye-bye.
Bye. Bye.
Bye.
Bye.